If you've been listening for a while, you know that I am a curious person and that curiosity has brought so much good into my life, including my business and this podcast. Well, when I met today's guest, I instantly knew he was a curious person who continues to want to learn and improve his practice to help his patients. Dr. Glassick is an orthodontist here in Charlottesville. I went to see him a few years ago to have a permanent retainer repaired, and he asked me about my work. He then shared how his daughter prompted him to be interested in learning more about sleep and how the structure of the face, mouth, airway, etc., can play a major role in our sleep and overall health. In more recent years, Dr. Glassick has been treating my girls, and I've been very impressed by his continued pursuit to learn more about the role he can play in improving children's sleep and health. I'm so excited for you all to join me for today's conversation. I guarantee that you're going to learn something new here today. Before we dive in, I just want to make a note that everything Dr. Glassick shares today is intended to be educational and should not be considered medical advice. Hi, I'm Allison Edgety, a pediatric sleep and wellness coach and a mom of two. I love to help parents find solutions. This is How Long Till Bedtime. Well, hi, Dr. Glassick. Thank you so much for joining me today. I've really been looking forward to having this conversation. Before we dive in, can you tell us a little bit about yourself? I guess more specifically, I'd really love to hear what inspired you to become an orthodontist. And since I've already shared that you're a dad, maybe you can tell us a little bit about your kids.
Of course, Allison. Thanks so much for having me on your podcast. I love the work that you're doing. Being a parent is not easy for sure. And it's so great to have a resource like this to provide us with more information on helping us to better raise our kids. I'm super excited to talk through some of the more rousing things that are happening in the world of orthodontics and also more specifically my practice. But I wish I could say that I always knew that I wanted to be an orthodontist from the day I got my braces off as a teenager. But my journey to where I am now is truly just a result of my experiences along the way. I went to dental school at UNC, and after I graduated, we moved to Denver, and I completed a 1 year general practice residency, which is essentially an additional year training for more advanced and difficult procedures. And after that, I practiced as a general dentist and taught at the dental school for about 4 years. And I loved it. I love working as a general dentist. But what I found out is that I don't like not being the best at what I was doing. And a good example of that is one of the things I had received more training in was dental implants. I was placing dental implants and doing that for some of my patients. And I always felt a little bit of guilt for it though, even though our fee was slightly lower than the surgeon down the street. They had done thousands more than I had and had more advanced training. So I just didn't feel good about it. Didn't feel like I should be the one doing it. So I wanted to be the specialist, the one who has the most training and is best at what they do. So I decided to go back into orthodontics, and it's been amazing since then. I love the relationships that we get to form with our patients and their families. I love creating beautiful smiles and giving people more confidence, and I love changing lives. The whole airway part of my practice is really, truly the cherry on top. It's another way that I get to help people out. And so I do have three little girls. Helen is 7. Virginia turns 4 in a couple days, actually, and Margaret just turned 2. And they're all super sweet and really bring me so much joy. And I think being a parent is probably the one thing that's shaped how I practice the most. I can, when talking over treatment options with patients and parents, I can truly say and think, what would I do if this were one of my girls? So it's been great for me.
And I always ask you, what would you do for your daughter
Yeah.
whenever we're talking about my kids?
Yeah.
When we first met, you asked me a little bit about what I do, and then you shared that your daughter had really inspired you to want to learn more about the structure of our faces and our mouths and how it can affect our airway and our sleep. Could you share that story with us?
Of course. My daughter's probably the most famous person in my practice, and she doesn't even know it. But Helen, who's my oldest, when she was 3, for some reason we still had a video baby monitor in her room, and I'm not sure why, but every now and then I check it out and notice see how she's sleeping. And over time, I noticed that she would sleep with her head tipped back and her mouth open, occasionally a little bit of snoring and some gasps here and there. So she didn't snore too often, but it was enough that I talked to Patty, who's my wife, and told her, hey, mention it to our pediatrician and who we love and see what she says. And she talked to her about it, and the pediatrician came back and said, she's probably fine. Don't worry about it. You don't need to worry about it now. She'll grow out of it and we'll be good. But I pushed back a little bit based off of some of the research I had been reading and things that I had heard about sleep apnea. And so our pediatrician was great. She happily referred us to an ENT. And so we saw the ENT here in Charlottesville. And a couple of weeks later, when we saw him, I showed him the videos of my daughter sleeping. And he immediately said, hey, she should have her tonsils and adenoids out. We don't even need to do a sleep study. The video is proof and shows it. But with my science background, I just wanted to quantify whatever was going on with her. So we ended up doing a sleep study, which was quite the experience. I was the one who went to the hotel with her. They hook her up to all the leads, and a couple of times during the night, she woke up trying to pull everything off. So it's not a super easy thing, but it was really important to me and to our family that we did it. But it came back that she actually had severe sleep apnea. And so he recommended she get her tonsils and adenoids out, which happened a couple weeks later. Then she immediately had an improvement in her sleep. Before, we had never really noticed the bags under her eyes when we would look at pictures of her. But if you look at a picture pre-surgery and then post-surgery, there's a clear difference of the bags under her eyes. And so there's no doubt it changed her life. She was a 3%er as far as weight goes on the growth chart. And one of the PAs had told us before the surgery, hey, watch, she's going to have a change in her growth. And she actually shot up to about a 25% or so. She started sleeping with her mouth closed, nasal breathing, and just had much more restful sleep.
That's awesome. Did you notice any change in her behavior?
She's always been our typical first kid who's just wanted to please us and has been really great. And I think she was young enough at that time that she wasn't super rebellious or anything like that. So no major personality changes for her. She did wake up with more energy and didn't have low points of dragging throughout the day. So I guess some minor changes.
I guess your 3-year-olds are not like my 3-year-olds. That was a
Well, that's our
traumatizing year.
yeah. She's our first. That's not the other two. So
Yeah, and my kids are flipped. My first is the one that gives me the run for my money.
mm,
So, I just love that story because I love it when our children make us better at what we do, and so I was so drawn to you immediately when you shared that story, and I think it speaks to your passion, and you have actively sought out opportunities to learn more and continue your education in this area, which I think brings so much to our community and anyone that hears this because I don't think it's widely known. And I know that you went to a conference, I think it was at Stanford this past year,
mhm.
and I'm really excited to further pick your brain. But can you just start with the basic explanation of how the structure of our mouths and our faces can affect our sleep?
Yes, absolutely. That conference was really an eye-opening conference for me. There was so much great information there and just new research that was coming out. But just for a little baseline throughout our conversation, I'll probably refer to both sleep apnea and sleep disordered breathing, something that's called sleep disordered breathing. And I'll try to not use them interchangeably, but for what they actually mean. So, sleep apnea is an actual diagnosis where breathing starts and stops during sleep. And then sleep disordered breathing is actually a spectrum of breathing issues that range from snoring to what's called upper airway resistance syndrome to full on sleep apnea. So, there are a couple of different things I'll refer to throughout the podcast. But back to your question, there is a sleep medicine center in residency at Stanford, and they are doing some amazing research. They're really improving ways that we diagnose sleep apnea and also how we treat it for both kids and adults. It's amazing. They continue to make new connections between our facial structures and the quality of our sleep. On a really basic level, there is usually some part of our facial structure, something like a tongue tie, a deviated septum, In kids, it's usually large adenoids or tonsils, fatty infiltration into the head and neck area that's associated with obesity, something like that leads to a nasal obstruction or airway resistance for a kid and adult. But for kids, that obstruction or resistance leads to the person becoming more of a mouth breather. And what happens when we become a mouth breather is that the tongue gets positioned lower down in the mouth, and it actually puts the pressure down lower that leads to the lower jaw growing more vertically or down, which causes the face to grow longer. And so, without the natural growth stimulant of air flowing through the nose and nasal breathing, we actually tend to see the upper jaw and the mid face, the nasal bone, the cheekbones, they fail to develop at a normal rate. And so that usually results in a deficiency of the mid face or the upper jaw there. And so you have this poorly formed upper jaw, which we call the maxilla. And when it's poorly formed, it actually affects the eye sockets, how the eye is supported, actually. Like I was mentioning, bags under my daughter's eyes. That was not necessarily skeletal changes right away, but sleep related, but it does affect the appearance of the eyes. It affects how the nasal airways are supported, which can then lead to a deviated septum and can lead to asymmetrical growth and then ultimately snoring and sleep apnea. So there's really a lot there, but something really interesting that researchers are also finding is that underdeveloped jaws can lead to our patients actually leaning forward with their head posture, as it helps to open up their airway more, but then obviously throws off alignment of the spine and the body. So poor posture, as we know, can lead to headaches, actually some grinding of the teeth, neck, shoulder tension, and fatigue. So there's a lot that ties into it, but the most common description for someone who has a restricted airway is called adenoid faces. And it's a term that was coined years ago, but it refers to someone who has enlarged adenoids and therefore have mouth breathing, which has led to that longer face, a narrow upper jaw. Typically, they'll have dental crowding, they'll have underdeveloped upper and lower jaws, lower lying soft palate, and a narrow nose.
So a lot of this, it sounds so extreme, but I think a lot of people are walking around and it's not like you might be looking at people and thinking like, "Ooh, I bet they have an issue." But the average person, you're not noticing these different structures, correct? Like they're not so extreme that the average Joe Schmo is noticing this.
Yeah, I would agree that most people probably won't notice it just walking around. I think in the more extreme cases, you could, if after hearing this, you could probably walk around and notice and say, oh, that person does have a little longer face and an open bite. Or if you look in and you can see their upper jaw is really crowded. When they smile, the top teeth seem tipped in or something like that. So on average, probably not noticeable, but I think in the more extreme cases, you'd probably notice it.
Yeah, even I go to a biological dentist out of Richmond, and he
Mhm.
asked me at our first visit, he said, "I'm looking at your face. I bet you're a mouth breather." And I said, "Oh my gosh." Yes, I think he thought it was because I have a long face. So
Sure.
he did ask because similar to you, he's very into sleep. And
Mhm.
he immediately just looking at me said, "I bet you're a mouth breather," which I thought, well, that's disturbing. You probably walk around everywhere and notice when people have issues.
Yeah, it's funny. It started back in dental school. We'd walk around and we'd notice things because we're learning all about it and notice things about people's teeth. But after ortho, you certainly walk around and notice and say, oh, that person's a class two. They have a deep bite or whatever it is. So it's funny how just second nature all of that becomes.
Now anyone who socializes with you at a cocktail party can be paranoid that you're analyzing their
Right,
face.
right, of course.
So that's helpful and interesting, the difference between kind of a sleep disorder versus sleep apnea. I think that's
Mhm.
a noteworthy designation. Some of the moms in my membership community were hoping that you would share thoughts on pacifiers and thumb sucking. And then I also want to circle back on tongue tie and lip
Mhm.
tie. So let's start with the tongue tie and the lip tie. Tell me what you know about that. And a big area I think where people are struggling is what to do after that procedure. Because I
Mm.
hear a lot of it didn't work. I hear that a lot from the moms in my
Yeah.
group.
Yeah, that's huge. I've been learning a ton about tongue ties over the past year or so. The official term is ankyloglossia, but it really is an area of great debate, along with sleep apnea in general. But in the dental world, there are lots of opposing views on it. And so, as we talk through this, or because of that, I'm going to include references to multiple studies throughout the talk, just to try and support what I think are the correct theories and the best treatment approaches or options for patients. So, for a tongue tie, there's great debate on what impact a tongue tie actually has on a patient and also whether releasing it releasing the tongue tie has a positive effect or not. And so one of the doctors that was at the sleep meeting that I was at in California is named Sarush Zaghi. He's a surgeon who's quickly becoming one of the leaders in diagnosing and treating tongue ties. And during his talk, he actually brought it up. He brought up the fact that it's so confusing to parents and providers on what to do about tongue ties, because you can read one study and it says, hey, look, releasing a tongue tie changes kids' lives. It helps improve quality of life and is great. And then you turn and read another study and it says, hey, it makes no difference. You shouldn't even do it. And so his response to that was that if you look at how the tongue tie releases are done, and then what you just alluded to, what therapy is done afterwards, you'll see huge differences. So when a release is done properly, meaning all of the attachment is released. So tongue tie releases can be done incorrectly where it's not fully released, and well, guess what? The tongue is still tied. But when it's done properly, and then when the appropriate therapy is completed afterwards, it's going to make a huge difference. So Dr. Zaghi published a study with some other leaders in the sleep world back in 2019, and they had followed 420 patients ranging from 2 years to 79 years old. So a huge range there, and they found that 87% of them had an improvement in their quality of life. And that was through, they decreased mouth breathing, snoring, clenching, and facial tension. So for their study, what they did is they did a full release of the tongue. And then they also partnered that with myofunctional therapy for at least a month before the surgery, and then actually 2 months post-surgery. Another study that had 37 patients, that was more for kids, it was about a year to 12 years old, showed that after a tongue tie release, there was speech improvement in about 90% of the kids, solid food eating improved in 83%, and sleep improved in 83%. So both of those show, hey, huge improvements. The tongue being able to move freely is really required for several things. It's needed for optimal speech, for chewing, swallowing, oral hygiene, sleep, breathing, posture, upper airway development, so many different things. And if the tongue isn't able to elevate to the roof of the mouth, then patients tend to be mouth breathers and they end up with a more narrow palate and all those other things we talked about before. So Dr. Zaghi talked about a rough progression for kids from birth to 6 years that starts with a low tongue posture. And so you have the low tongue posture or the tongue tie, and that leads to mouth breathing, which that leads to noisy breathing, which leads to snoring, and that ultimately leads to sleep apnea in these kids. And so another more technical way that we say it is that the tongue tie causes the low tongue pressure, which leads to abnormal facial growth, which again, what we were just talking about, the structure of the face, and that causes mouth breathing, which results in some sleep disorder breathing. So an important thing to understand with that, though, is that tongue ties aren't the only cause of low tongue posture. There are two other things that he classified, which were tongue tone and tongue space. And those are potential causes and are harder to tell on your own. I mean, you can really look in the mouth and say there's not much room for that tongue. But tongue tone is also, some people's tongues just need to be trained a little bit. So these are cases where a myofunctional therapist can really step in and be super effective. There's a recent study that showed there's a decrease in sleep apnea in 50% of adults and 62% of kids with just myofunctional therapy. So no surgery, no orthodontics, nothing like that. They just did myofunctional therapy and it improved their apnea, which is pretty huge, I think. But so in addition to improving apnea on its own, myofunctional therapy is a huge part in preventing relapse for patients who've had their tongue tie released. So there really is a ton of information out there. I could go on and on about it, but it's hard to tell what's legit and what's not. And so for parents listening and for anyone really, I'd make a recommendation that I do for parents and patients in my office is to go to Dr. Zaghi's website. It's just www.zaghimd.com. It's ZAGHIMD.com. He's the surgeon I had mentioned earlier, and his webpage is awesome. He puts so much information there that at the top of the screen, it says educational resources, and then you can go to tongue tie. He's got all sorts of diagrams and studies, helps you understand potential problems, how we diagnose them, and how we treat the tongue tie. So it's a great resource.
That's awesome. So we'll link to that in the show notes. Can you tell us exactly what myofunctional therapy is?
So a basic version of it is it's like physical therapy for the tongue. Myofunctional therapists are specialized in the tongue and training different tongue exercises to help patients become more used to certain movements of the tongue, how to form certain shapes with the tongue. And so there's that one side of it. They also train the tongue on where to position more. So if people oftentimes, I think what relates to the improvement in sleep apnea is they help retrain where the tongue should be positioned. So the tongue to position up at the roof of the mouth when patients are resting, that kind of thing. And then the third part of what they do, so not only help retrain positioning, help strengthen the muscle in certain ways, is they help with exercises post surgery that help prevent the tongue tie reattaching. So it helps prevent scar tissue. So after a surgery, they'll give certain movements that a patient should do that will help prevent a tongue tie reattaching. So those are the main things that a myofunctional therapist does. That actually also brings up back to your original question of parents say, hey, a tongue tie release was done, but it didn't help. One of the more common times now that a tongue tie is released and it should be, is when infants are a couple days old and they're nursing and their latch isn't good. And so releasing a tongue tie can actually help significantly with that. And I see a lot of patients in my practice who are now 8, 9 years old. I'll look and they have a tongue tie, and I'll mention it to the parent, and mom will usually say, oh, yeah, we already had that clipped. We had it clipped when he was an infant. And then I have to say, well, it's reattached. And I'll usually say, did they give you any exercises to do after it was clipped? And they always say no. And so this is a little bit out of my wheelhouse, but my understanding is that after a tongue is clipped for an infant, they should give exercises of the parent should be doing some manipulation on the floor of the mouth and stuff like that to help prevent scar tissue from causing the tongue to reattach.
Yeah, because I'm assuming a myofunctional therapist is obviously a specialty, and not every town is going to have one. So, do you think they do it virtually?
So yes, I think virtual myofunctional therapy is a potentially great way to go. As you mentioned, there aren't myofunctional therapists in every town. And so there are some that are becoming much more well known, some on YouTube that provide basic exercises to do. But I think it's always best to establish a relationship. I always like in person when you can, but sometimes it's just not possible. And so I think that virtual treatment has become much more of an option just with how much cameras have improved, and the myofunctional therapist can watch our kids through the camera. So it is something that I would certainly explore and encourage parents to do if otherwise they wouldn't have any access to a myofunctional therapist.
Great. All right, let's talk about the very debatable pacifier and thumb sucking
Yeah.
and how it relates to the structure of the mouth, and just what your thoughts are with your practice and how you see that play out.
Yeah, so this is a really great question, and I don't feel like there's a clear-cut answer for this. The American Association of Pediatrics, they don't usually recommend treatment until a patient's 5 years old or until what they say the permanent teeth start to come in. I personally feel like that's a little bit late. A friend of mine who's a colleague of mine as well, her name's Rebecca Bachau, and she's a leader in airway and facial growth. She's an orthodontist up in the Pacific Northwest. She actually, I was talking to her this week. She recently completed a literature review on this topic. And what they found is that adverse skeletal changes, so bad effects on the bite or on the facial development, occur if non nutritive sucking, so thumb habits, pacifiers, if it persists past 18 months of age. So 18 months is obviously much younger than 5 years old. And so my guess is that more of a priority is going to be placed on stopping these habits earlier as more research is done. I think the really hard part about it, though, is that these habits can be so soothing for infants and toddlers, and breaking the habit itself is difficult alone. But as a parent, it's like, oh, I don't want to make them stop because it helps them sleep. So, and unfortunately, there isn't one perfect treatment modality that works every time. So my recommendation to parents would be just to start discussing it early with their pediatricians and pediatric dentists. Try to stay ahead of it if you can. As medical professionals, we've all gotten a little bit of training on helping to stop the habits, and I feel like it's best to start early.
Interesting. Yeah. So both of my girls were very into the pacifier, and their dentist had said, by two, make sure it's nowhere other than the crib. Like, it
Yeah,
needs to only
yeah,
be related to sleep. And then by three, it had to go. And I will say, Ainsley had a huge overbite. Like, didn't even have a
hmm
chin. And
hmm
he kept saying, if you just throw it out by three, in 6 months, you're going to see a chin develop. And I thought, this seems really too good to be true.
yeah,
But we did. On her third birthday, we threw it out, and I help parents get rid of the pacifier all the time. But six
hmm
months later, she did not have the overbite anymore. That totally corrected. Now, both of my kids
Yeah.
ended up with a side bite that you're fixing. So I don't know if that had
Yeah.
to do with it, but it was amazing once we got rid of it. Her mouth started to change.
Yeah, it's pretty kids are amazing, honestly. It's the way that they can grow and adapt. And so oftentimes if there's something that is causing adverse growth, if you remove it, the body will often recover quickly and on its own. Typically with to your question of how does it relate to the structure of the mouth, obviously a thumb habit, it's more of a sucking pressure. So we typically see a more narrow upper jaw. We'll see those top teeth flared out. And oftentimes, like you're mentioning, the lower jaw is kind of held back. So there's really significant things. And again, when the irritating factor is removed early enough, kids will often correct themselves, which is awesome.
And is there anything that can't be fixed down the road? So if
Mm.
people are listening and they're thinking, oh my gosh, my 5-year-old is still sucking their thumb. Obviously, we want them to address that. But is it, can you fix all of the things related to a pacifier use or thumb sucking, or is there some of it permanent?
We can typically or usually correct everything if the child's brought in early enough. One thing that we'll talk about later is phase 1, phase 2 treatments, early intervention in orthodontics. And with the early intervention, we're able to affect bone growth much more easily than we are as adults. So if we wait till they're adults, there's nothing that can be done outside of a jaw surgery. Jaw surgery is the only way to correct it at that point. And so the answer is yeah, you could correct it. It's just a lot more involved. At a younger age, though, we're typically able to get in, make skeletal changes to help normal growth occur. But again, that's earlier treatment. That's 7, 8 years old. Not even when kids are getting to 12, 13, it gets really difficult for us to fully correct some of the bites that come about because of habits.
Okay, cool. Well, let's switch over to some of the orthodontic work. So, when you and I were kids, people got braces once. I really
Mhm.
don't know anyone that got braces twice unless they totally screwed up their treatment. So, I have had a lot of people talk to me about the fact that my kids already have braces on their teeth and they're both pretty young. I did have an expander before I had braces, but my girls have the expander and the braces, and it's going to be 2 phases most likely. So they'll get
Mhm.
braces
Mhm.
a second time. And so I get lots of questions about it. I just say, well, that's what Dr. Classic suggested I do,
Yeah.
and I trust him. Tell me a little bit about why this is the new recommendation, because I specifically had some people say, "Is this evidence-based?"
Yeah, so in orthodontic residency, we're trained that there are certain types of bites, or what we call malocclusions, that are best treated with early intervention. And it's because of what I just mentioned earlier. We're able to correct these bites more easily at this earlier age because we're able to have a greater effect on their growth. We can actually alter their bones, the width of their bones, and stuff like that. So it's much easier to do at that age than we are even just a couple of years later. And so some bites for which we typically will do early treatment are cross bites, where the top teeth are inside the bottom teeth. So it happens on the back or on the sides and also in the front. Underbites, where the lower teeth are out in front of the upper teeth. Cases of severe protrusion of the top teeth or where they're sticking way out. That's when people usually call it an overbite. Kids who have severe crowding, very deep bites, actually crooked teeth that are causing social issues for kids. This is becoming more common with bullying and anxiety, that it is actually a reason to jump in early and correct or straighten up some teeth. And all of this is obviously in addition to the airway issues that we've already been discussing. So phase 1 of treatment is intended to be more proactive in nature, and it helps address significant problems early before they become much larger problems later. And so the usual goals for a phase 1 are to we correct the bite in a manner that is going to allow natural growth to occur in a more ideal manner. So a good example of this is that if a child has a cross bite, meaning again the top teeth are inside the bottom, that can lead to asymmetric growth of the face of those jaw bones, because the upper jaw might be able to grow unrestricted on one side, but then it can't grow normally on the other side. So we want to allow natural growth to occur. We can correct skeletal asymmetries. We help to avoid tooth impaction. You reduce the risk of trauma to those teeth by bringing them back in if they stick way out. And also, we use it to reduce the need for adult tooth extraction. So back to your original question on why it seems kids are having it more treatment earlier, I think it's related to a couple of things. Our national organization, the American Association of Orthodontists, has really made a concerted effort to try and educate lay people that the best time for a child to have their first orthodontic exam is by their seventh birthday. And they're really starting to push this. And that goes against what was the typical, oh, I got mine when I was 12 or 13 years old. And so I think there's just a more highly educated population out there, both dentists and parents. And so they have a better idea, hey, that's when we need to get in earlier, and say so we're able to jump in a little bit earlier there. And then another part of it is that there's always been a pendulum in orthodontics on treatment philosophies related to the extraction of adult teeth. For a while in the past, many more orthodontists recommended taking out adult teeth to help address developing crowding. I think to the tune of like 35 to 40% of patients had extractions in the past, versus right now it's quoted to be around 15%. So believe it or not, when you take out teeth, it actually makes the orthodontics a lot easier. And there are some cases where patients still do need extractions these days. And it's just if they have severe crowding and we can't make all the teeth fit in together in a healthy manner. And so we can't become too dogmatic in our non-extraction approach, because if you do that and we just say, hey, we can't take any out, you can risk causing periodontal problems, lip incompetence, open bites, and stuff like that. But all of that being said, the current trend is more towards the non-extraction philosophy. And so I think a lot of this is related to, there's now a greater focus that we have as a profession, I think in as society, on the soft tissue of the patients, meaning their lip fullness, their profiles, their face, and just trying to maintain that fullness. And so a pretty well-known adaptation in humans is that our jaws are getting smaller as our diets have become softer and more refined. And so when they go dig up the jawbones of older skeletons, they're much larger than ours. And so it makes sense that as our jaws continue to get smaller, we're going to see more and more crowding of the teeth, more potential jaw problems than we did in the past. And so these are all usually treated much more easily at a younger age, because all of the sutures between our bones haven't fused yet. And so again, we can more easily affect that growth and help correct those issues before they become much more significant.
Yeah, people ask me all the time what even made me go get the girls evaluated. And in part, I
Yeah.
think two things. They go to a pediatric dentist. So I think they're thinking about it
Mm-hmm.
more than maybe the average, just typical dentist. And so I talked about it with him. And then also, my girls have huge teeth, which I have big teeth as well. But when I was a child, my parents took me, I think, to three different places because the first person
Mm-hmm.
wanted to take out my adult teeth. And so we went on this cycle, and ultimately I did not have teeth pulled. I don't know if that was good or bad. But when I tell
Yeah.
people this, like, oh, my kids have big teeth, I'm hoping they can keep them all. And I swear 90% of them say, oh, yeah, I had adult teeth extracted. I'm like, wow,
Right.
it's a lot
Yeah.
of people.
It is. It really is. And actually, I say big teeth are beautiful teeth. I love having big teeth because when we straighten them, the smile looks amazing. So I like that. But yeah, it was much more common. And it really is, like I mentioned, oftentimes easier to straighten the teeth and get the bite to come together well if we take out teeth. But again, I don't think that necessarily makes it the right choice. And so we, in our practice, tend to be much more non extraction when we can. And there's always a limit on what you can do, but we love having good full smile, seeing teeth from corner to corner. And so I think we can achieve that a little bit better without taking out teeth.
Awesome. Well, I know at your practice, you are looking for signs of sleep apnea because you even do a questionnaire when I first came
Hmm.
in, which I loved. And obviously, we've talked about there are multiple things that could result in a child having sleep apnea. But I'm curious if you have seen early orthodontic intervention improve children's sleep or help prevent them from ending up with sleep apnea.
Yes, this is one area where there's just some really great research coming out that's being done. And so I've seen it firsthand with my daughter, and I've heard from multiple parents that their kids are sleeping better. I mentioned earlier that Helen had her tonsils and adenoids out when she was 3, but when she was 5, I actually felt like she wasn't sleeping as well as she had been immediately after having her surgery. So I ended up actually treating her with an expander, which improved her sleep pretty quickly. And a lot of times people say, well, she only had baby teeth then, and she did only have baby teeth then, and it was totally fine. It's actually, expansion is actually much easier at that age than later in life. And so we do it a little bit differently, a little slower. So there are certain things we needed to do it right, to do it correctly, but it worked great. And then from the scientific standpoint, as of a couple of years ago, there were at least 17 studies that showed using a palatal expander improved obstructive sleep apnea. And so on average, through all of these studies, someone put them all together. They looked at what's called the AHI, which is the apnea hypopnea index. And that's not really important outside of knowing it's how we measure and quantify sleep apnea. But on average, that number dropped from 9 events an hour to 2 events per hour, which corresponds to a reduction of around 70%, which is huge. That's just from an expander. And so another study that just came out this year was done by a woman named Audrey Yoon, who's an orthodontist in California. She's associated with that Stanford sleep team and is amazing. They found that for patients who had an expander, 90% of them had a reduction in the size of their adenoids. And then 98% essentially of them had a reduction in the size of their tonsils. And so the average reduction was about 17% for adenoids and 39% for the tonsils. But that's huge. So
So
based off of these findings,
why
go
would
ahead.
that happen? Why would that reduce the size?
Yeah, so that's a great question. And I think the reduction in size is really related to, so the expander obviously creates larger airways, which is leading to less airway resistance on breathing. And I think the idea is that it leads to the tissue is initially irritated and inflamed. And so as the kids are able to breathe better and sleep better, there could be a systemic response. I don't know that they actually showed exactly why it happened, but there was an actual reduction in the size. So I don't know if it was due to the flow of airway over the adenoids and tonsils or if it was related to systemic response. But I think it's pretty cool that there's an actual volume reduction in the tonsils and adenoids.
Good old inflammation. It gets us
Yeah.
everywhere.
Yeah. But
And I know. Go ahead.
sorry, the really cool thing about this, or the important finding is that, or why this is important, is that there are actually some studies that show that having tonsils and adenoids out does not lead to complete normalization of breathing for kids with obstructive sleep apnea. So, and what I mean by this is that sometimes kids will get their tonsils and adenoids out and their airways or their sleeping doesn't improve. There's a big study that showed normalization was only achieved in 25% of the kids after surgery. But there are other studies in general have shown that residual apnea occurs in 13 to 29% of patients. And so there's obviously some great resolution there. But these studies show that, hey, surgery alone oftentimes does not take care of it. And so it doesn't mean that removing adenoids and tonsils doesn't work. It just means that we need to be diligent about monitoring our kids' sleep after they have surgery. And when the surgery is effective, we see improvements in attention, learning, behavior, and overall quality of life. But if it doesn't work, then oftentimes an expander can step in and help with that. So along these lines, a couple things that I want to emphasize about our practice. You mentioned that sleep questionnaire that we have patients do, and it's called a pediatric sleep questionnaire. It's PSQ. And what we're looking for is more than just outright sleep apnea, and it's more aimed at treating any kind of sleep-related breathing disorder. And anytime we do that, it really does require a team approach. It's not just, hey, the orthodontist takes care of it. So a lot of the signs for sleep apnea for people to be aware of, the major ones are mouth breathing, grinding, bedwetting, behavioral issues, ADD, snoring, stuff like that. Really interesting study that I just read about is that primary snoring. So it's usually we think, oh, kids are snoring, no big deal. But so it's classified as this benign form of sleep disorder breathing, but it's actually pretty significant and shouldn't be ignored. Kids and adults, of course, are going to snore when we have allergies flaring up or we have a cold. But if kids are snoring pretty consistently, it is something that should be explored further. There's a study out there that showed that 37% of kids who snore, so that's a large number, 37% progress to having sleep apnea, and about 7% of those have moderate to severe sleep apnea. And in those kids, they showed an increase in blood pressure, a higher risk of hypertension and metabolic syndrome later in life. It's also been shown to cause developmental delays, behavioral problems, poor performance in school even. And so it's something that certainly shouldn't be ignored. And the second part that I had mentioned that is really important to emphasize is that even though these expanders have been shown to improve sleep apnea, treating sleep apnea in kids is always or should always be a multi-specialty approach involving myofunctional therapists, ENTs or pediatric pulmonologists, orthodontists, speech therapists when needed, and so on. So that PSQ, that questionnaire in our office, helps indicate when a child's at a higher risk of sleep apnea, but it doesn't create an official diagnosis. It helps give us a pretty good idea of when a patient's having sleep disorder breathing, but an overnight sleep study is still the only way to formally diagnose a child with sleep apnea.
Yeah, and one thing, and I don't like to throw pediatricians under the bus, I always say they
Mm,
can't be experts in all areas.
mm, yeah.
And so, what I encourage my clients to do when they have a child who's snoring and they say, "But my pediatrician said not to worry about it," I usually say, "Well, just ask them, tell them you'd like a second opinion from an ENT. Is that the route you would send someone if their pediatrician is saying, 'No, I think this is fine. We can just let this go'?"
Yeah, I think that's a great way to go is to encourage that. I always tell parents, pediatricians are amazing because they're such great non-alarmists. We come in as parents, we're like, oh no, something crazy is going on, but they do a great job of kind of talking us down and things really will be okay. And so I think this is another area that applies. In medicine, we used to always say, and some people still do, hey, kids are going to grow out of it. So their tonsils are too big, but guess what? They're going to grow out of it. And now the reality is that we grow into it. Kids' face shape changes and it can affect so many behavioral things. And so it is something that's worth pushing through. And so I would encourage parents to either push through, say, hey, can I go see an ENT, or even find an orthodontist locally, because it's becoming big in our world, or a more important topic in our world as more and more research is being done on it. And so I've also found that oftentimes our literature, the medicine literature and the dental literature, we're going not two different ways, but we're looking at different things. And so in some ways, the literature that's being done in the orthodontic world is ahead, these studies that are ahead of some of the things being put out in the pediatric journal. So sometimes it's just they haven't seen the stuff that's coming out, but it is certainly worth, if a parent thinks something's going on, to push through and have it explored.
And one thing you just referenced it, and I wanted to bring it up as well. You mentioned bedwetting. One day when I
Mm.
was in your office, you told me that you had just had a young patient whose bedwetting stopped after they had their orthodontic treatment. I can't recall what you said that they had done, but that to me is an example of life changing treatment. I mean, if you're a child
Mhm.
who's older than you would think would be bedwetting and that can change, I think that's amazing. So, can you just elaborate on that and how that could happen?
Yeah, absolutely. So, as far as I know, I don't think anyone fully understands the connection between airway issues and bedwetting, or what we call nocturnal enuresis. That's the formal term for it. But there are a lot of theories that associate sleep disturbances that cause increased abdominal pressure and altered blood pressure, which leads to the bedwetting. But I don't know that's been universally accepted. But either way, like you mentioned, bedwetting can be really embarrassing and and a socially limiting issue to deal with. And it's actually a lot more common than most people know. It's not uncommon. Probably every week I have a patient come in who's 9, 10, 11, who is still wetting the bed some. And so it's obviously usually an embarrassing thing for them. They don't like to talk about it, which is fair, but it's important to talk about, at least with medical providers. And so many studies have made a connection between sleep disordered breathing and bedwetting. So there is oftentimes a connection there. And oftentimes, medical interventions fail in treating it. And so it's important to explore other modalities of how we can help address it. And so, an interesting thing I thought is that, for back to the snoring, for children who habitually snore, which is when they snore 3 or more nights a week, which is a lot of kids, they're 3 times more likely to wet the bed, meaning 7.5% versus 2%. And so, a large study of kids who had sleep apnea, 68% of them also wet the bed. So there's a huge connection there. And as far as treating it, there's a study that was done that showed that kids who had nocturnal enuresis and then had their tonsils and adenoids out, that 52% of them had complete resolution. And so sometimes the resolution is immediate and sometimes it takes up to a year. And obviously 52% is not 100%. So it wasn't everyone, but at least it did help out for some. There's other success that's been reported with expanders, which is kind of what you and I were talking about that one day. But expanders, there's a study that showed 74% of kids in a study improved in their bedwetting. Another study of expanders showed 70% of kids within 1 month had improvement, and 40% of those were totally dry. So, in all of these studies, this is important, I think, were completed with kids who had undergone other medical treatments for bedwetting that had not worked. So there's really great potential upside for treatment with really minimal adverse effects. And so, of course, it doesn't correct it for everyone, but it's one of those things that, I mean, 70% is pretty great and it's a pretty minimally invasive thing to do. So I think it's a great option for parents to consider.
And it's something you might be wanting to do even putting bedwetting aside, your child
Yeah.
would benefit from it, so it's almost just like this bonus benefit.
Yeah.
That's
Yes, you're exactly right. All of these things really just tie in together. We see that narrow upper jaw, which we want to correct for an orthodontic reason, just to allow natural growth to occur. So, in correcting that, we actually improve the airway, which could help sleep better and could help cut down on bedwing. So, they all are, so many of these things are tied together. And so, it's great that we're learning more on how we can help improve so many different aspects for a kid.
Yeah, are there other areas where you've seen improvement that people probably would be surprised to learn about? Like, I think people are gonna be surprised to learn that orthodontic treatment could help bedwetting. Are there other things that have surprised you or that parents are surprised to learn about?
Yeah, this is one of the main reasons that I truly love what I do. I get to see people's lives transform every day. So in thinking about our patients with sleep apnea, we've talked about it some, but they've been shown to cause behavior problems. Sleep apnea has been hyperactivity, ADHD, impaired performance at school. There's some studies that are showing that if kids get behind at an early age, they actually never catch back up all the way through high school. It's shown an 11-fold increase in risk of what's called left ventricular hypertrophy, or the heart's enlarging when it shouldn't be, and also an increase in daytime, nighttime blood pressure. It's been shown to cause metabolic issues in kids, which including impaired glucose metabolism, bedwetting, all these different things. And some of those things, obviously, I'm not measuring metabolic issues or blood pressure, but helping these patients is hands down one of the most rewarding things for me. And it's something that I wasn't expecting when I first went into ortho, but it's been such a delight as I've learned more about that. And so outside of that, of course, the positive changes we get to do, or we just get to help people smile more. And how awesome is that? There are all sorts of studies that have been done that emphasize the importance of a smile. So, how huge of an impact it has on first impressions, how people actually judge others based solely off of how their teeth look. And every day I get to help patients with that. I get to help improve their self confidence and their ability to express happiness and joy. And it's become a much bigger thing with bullying. That it's great to be able to help kids who, and adults actually. What some of my best days are when I have a patient who's 60 years old and comes in and shares, "Hey, I'm smiling more now than I ever have in my life." And so those are things that are expected with an orthodontist, but are truly life-giving moments for me. So we obviously improve patients' ability to chew, their speech, their ability to keep their teeth healthy for a lifetime. So many different things. And it's awesome that we get to have such a positive impact on the whole person. That's such a rewarding thing for us.
I do think it's really cool because in a way you can just think of the orthodontic treatment as well, we want them to have straight teeth, or do I care about that much? It's not a cheap venture.
Mhm.
So
Right.
where do we prioritize it? But what I think of in addition to how great it is to have a great smile, which I completely agree with, to think that there are other health benefits, I think is
Mhm.
important for people to understand because for me personally, it was a big motivator to start early with my children because I thought, okay, well, if there's other health benefits, let's dive right in and get going on this process. So I think that's helpful. And you've mentioned there's the recommendation of bring them in by
Mhm.
7, but then you've also mentioned that you treated your daughter at 5 with the expander. So I'm really curious for you personally, people listening, and they've got the 4-year-old and they're thinking, okay, when do I take my child in to see the orthodontist for an evaluation? What is your personal recommendation?
But anyway, so yeah, for most patients, we do recommend that they schedule their first exam around their 7th birthday. Again, we talked about it before, but this is so we can check to see if there are any potential issues that might cause issues with normal growth or development of the jaws and the teeth. So many patients that we see at this age, they end up not needing treatment for a while, and so we follow them for every year or so to monitor growth until they're ready for treatment if they even need it. And so the first visits that we have are usually really easy, and they're intended to help get the patients familiar and comfortable with our office and our team. So we have them come in, we take some pictures, we'll take an x-ray, and we complete a basic exam looking at the patient's teeth, tonsils, tongue, their joints, stuff like that. We throw a couple high fives in there. We talk about things that we should watch for, and then we make any recommendations if treatment's needed. And so and all of these consultations are complimentary in our office, and it's really just a way to try to encourage to remove any barrier to parents to bringing their kids in earlier, because oftentimes it really is much easier to correct things earlier. So again, you just mentioned that the only exception I'd make to this general recommendation is for parents who think their kids might have some form of sleep disorder breathing, or they're just not sure. There's no official age recommendation for this, and so I would just tell them schedule a consult as soon as they can. So an orthodontist can help evaluate if further investigations needed into potential sleep apnea. And it might be something where the orthodontist looks and says, nope, we're good. We'll see you back in 3 or 4 years. And that's really, they're able to clear and understand that normal growth will occur. But the incidence of sleep apnea in the pediatric population is around 1 to 7%, depending on what study you read. And I think that number, and oftentimes it's just viewed as being underdiagnosed because a lot of people just don't know about it. But the peak incidence of that is seen at the preschool age from 2 to 5 years old. So kind of what you're just saying, if a parent has a 4-year-old and they think, hey, something might be going on, best to get in and get seen early. And so again, like we've said over and over, the earlier sleep apnea is addressed, the better.
Yeah, and one thing that I think is so interesting is there's more coming out on children getting misdiagnosed with ADHD when they're really sleep deprived. And there can be a variety of reasons a child is sleep
Mhm.
deprived. It could be sleep apnea, it could just be that they have poor sleep habits. And for me, one of my greatest joys, and I'm sure you feel the same way, is when I'm working with a preschooler, which I work with a lot of preschoolers, and they say, oh, their behavior has improved
Mm.
so much since they're getting adequate sleep. And so I put this orthodontic evaluation in that same camp. So you can treat the behavioral piece, you can make sure we aren't dealing with a sleep disorder and make sure they're breathing well and getting high quality sleep. It can make it so they don't get misdiagnosed down the road as well.
Yeah, so many of these things are multifactorial, and I think orthodontics is often not thought of as a potential solution. And it isn't always the solution for sure, but it's one of the more easier routes to go to jump in and help. Like you said, I think a lot of kids in the past were diagnosed with, and still are diagnosed with ADHD when they're actually just, they have sleep apnea. They're not sleeping well. So tired kid and ADHD could often act in similar ways. So it is a great way to get in early and get an evaluation. And some parents come in thinking, hey, this is what it's going to be. And I have to say, I don't actually see anything. I don't see a connection there, but oftentimes there is a connection. And it's really fun in my office when I have them fill out that sleep questionnaire. And as the parents are going through it, I can see the light bulb just coming on like, oh my goodness, there are so many of these things that are connected and these long conversations about it. But it's great because it is a potential solution for a lot of these things that I think people often just say, that's just how my kid is.
Right. Well, this is awesome. Before we wrap up, I'm curious what the biggest thing is that you wish parents knew as it relates to the work that you do.
Yeah, this is good. This doesn't directly relate to the structure of their child's mouth necessarily, but I always like to reiterate to parents that they are their child's best and most important advocate. They know their kids the best, and if they're suspicious or worried something isn't right, they should look into it. Patty and my wife and I are so glad that we pushed into it with our daughter. We pushed into it to having her evaluated because even though she was initially said, hey, she's okay, it was life changing for her. And so all of that, this is a little out of context, but it reminds me of this song my girls love to sing from the movie Tangled, and it's called Mother Knows Best. Mothers and fathers typically do know best, and they should really follow up on those feelings.
I love that. Well, thank
Yeah.
you so much for your time. And thank you for being curious and someone who always strives to be better at their trade. Every time I come to your office, I'm just impressed with something new that you share. Before we wrap up, though, can you tell everyone how they can find you if they're interested in coming to see you?
Yes, you're certainly welcome. I'm so glad this worked out for me to be on your podcast. Thanks so much for having me. I think it's awesome. I think the incidence of sleep apnea is only going to increase. And so it's so important that we do everything that we can to inform and educate patients and parents. But if someone wants to find me, our practice website is www.sevillebraces.com. I think that'll be listed later. But you can go on there and you can click on the contact us link and it'll give you email and phone number. Or if you just want to skip that, just email us. Our office is info@sevillebraces.com. Our team will get that and they'll pass it along to me. And then you can also call us at 434-296-0188. You'll talk to one of our amazing team members and they'll help you from there. So
Awesome. And we will put all that info in the show notes. Well,
perfect.
thanks
Thank
so
you so
much.
much. Yes, thank you. This has been great.
Thank you for listening to How Long Till Bedtime. To learn how we can work together to improve your child's sleep, please visit sleepandwellnesscoach.com.